Yeah, thank you so much. It's an honor to be here in this amazing group. And in honor of Women's Day, I will say that my son is homesick. So, like many of us, I'm multitasking and both being a mom and working from home at the same time. So, if I have any interruptions, I'm sorry about that. Um, Okay, and I hope that this can be interactive. So if you have a question throughout, please just stop me and pause me, and I'm happy to break it down. I have about 25 minutes of slides, I think, but I'm happy to pause and take more time at any area that people want to talk more about. And if I don't get through all my slides, that's fine. Um, so first, to start out a little bit about my background, I thought I would share with this group. So my family is from Cuba. Those are my grandparents. My mom was born in Havana and then moved to the United States, to New York City, when she was 7 years old. And there she met an Italian immigrant and had my sister and I. And we both went on in our own ways. But I think that that background really shaped my interest in health equity. I went to undergraduate at Stanford in California, and there I worked at a free health clinic. And during that time, really interacted with a lot of other immigrant families from Mexico and Latin America. And I began to really learn more and see about the different drivers of health, social drivers of health, how race, poverty, immigration status, language all affect people's health, and really became passionate at that time about a career kind of trying to reduce health inequities that I was seeing. So when I went to medical school, I went back to New York to Stony Brook University and lived with my parents because they live right over there. And during that time, I not only got my medical degree, but I went to school at night to get a master's in public health as well, to learn more about these kind of social drivers of health and get more tools to do community health and more public health. Then I came to Duke in 2012 for my pediatric residency. And at that time, I didn't know exactly what I was going to do within healthcare, but I wound up becoming a pediatric hospitalist, which basically means I take care of children when they're sick in the hospital. And I was still committed to health equity and initially was doing some racial equity work in the medical school and advocacy. But as I was a clinician longer, I became really interested in the way that patients and families and healthcare systems interact with each other, just noticing inequities in the way that people were being spoken to. And so then my research really, I became interested in that, both on my clinical side and also through stories of my family and extended friends and family. So I'm going to talk today about kind of health inequities in communication between patients and families and providers, which is a general term, can be doctors, nurses, and other members of the healthcare team. And then I'll also talk about some of my research in this area as well. And please, Gabby or Viviana, if there's a question, feel free to interrupt me. I'm not going to look at the chat. So first, talking about some inequities in communication by language. So I look at both by race and ethnicity as also language factors. And a quick note about terminology. So, a lot of us are familiar with the term limited English proficiency. However, this term itself is coming out of favor a little bit in academic circles. It's really focused on the deficit or lack of proficiency in English and may feel more stigmatizing. And it's really a term that comes from the US Census about how well do you speak English. But some individuals may speak English very well and yet still prefer their medical information in a different language due to the nuances and complexity of language and healthcare systems. And so there's been a push to shift away from limited English proficiency to language other than English for medical care. And it recognizes here that language can be more context specific. So first, just why this research and this study is important. So when admitted to the hospital, patients and families who speak a language other than English have worse both experience and outcomes. They have lower understanding and satisfaction, up to 20,000 higher hospital costs on average and longer hospital stays, an increased risk of being readmitted to the hospital after they go home, and notably a 2 times higher risk of having a serious medical event error or adverse event while they're in the hospital, and also even increased risk of mortality. And we know that when interpreters are used and used effectively, that it can mitigate some of these inequities that we see, but that interpreter use is still underutilized in healthcare settings, specifically the hospital. And so there was a recent survey where they asked different hospitalists who take care of children, it was a pediatric hospitalist survey, whether or not they had access to interpreter services. And over 90% had access to either a video, in phone, or in-person interpreter. And actually in this study, 3/4 had access to an in-person interpreter for common languages like Spanish, Arabic, Mandarin. And then, but despite that access was increasing, in this same study, only 40% reported that they always used an interpreter for rounds. And rounds is really the main time of the day where the medical team will go into the room of children in the hospital and talk to the patient and families about what's going on in their plan. So even for that very critical moment in the day, despite having access, people aren't always using an interpreter. And then it's even less true when they ask nurses about how commonly they'll use an interpreter for things like giving a medicine. Only about 10% of the time are people using an interpreter when they go into the room for these quick interactions with patients and families. And on average, some institutions that have looked at this found that they're using an interpreter for a child in the hospital about 1 to 2 times per day, which might be like, okay, well, that's pretty good. But then when you think about the number of times that people are going into the room of a hospitalized child every 4 hours to get vital signs, to get food services, the medical team going in to check on them multiple times a day, all of these instances, if there's only one interpreter used per day, all of these processes are not being interpreted. And those are opportunities for an English-speaking family to speak up or to ask questions that a family that speaks another language is not having. And there's actually been one study that looked at how often an interpreter is used and then what happens in the hospital. And so children who are admitted to the hospital that an interpreter is used less than once per day, they have an increased risk of winding up in the ICU during that hospital stay. And so one of my colleagues, Michelle White, who's another pediatric hospitalist at Duke, wrote a commentary about this, and she said, each time a member of the medical team goes into the room of a patient who speaks a language other than English without an interpreter, it effectively silences that family. There's also been some studies that showed a lot of variability in how teams work with interpreters. And so I mentioned briefly different modalities from in-person to video to phone. And overall, in surveys of families and also interviews of families, individuals prefer an in-person interpreter. You get that body language and cues and rapport that you're not offered with a video interpreter. Bilingual providers in some of the studies in the hospital setting have been mixed whether or not patients prefer that. And in part because when they're in these large teams, bilingual providers tended to kind of talk amongst the team and then summarize information to the families rather than provide true word-for-word interpretation the way an in-person interpreter would. And so kind of there's some mixed whether or not that's the most effective and preferred modality. And then also some studies that have observed communication happening in the hospital seem that there's a lot of variability in how much of the conversation was being interpreted. So a lot of times there's just this summarizing at the end of a conversation rather than pausing every 1 to 2 sentences to allow for interpretation to occur. And that there's more side conversations that happen in families who speak a language other than English. So when the whole team is in that child's hospital room discussing their care, there tends to be more side conversations between team members that don't include the patient and family when there's an interpreter supported rounds. And then lastly, in various settings, in speaking with families who speak a language other than English, the doctors seem to dominate the conversation more. Patients speak less. And when patients do speak, their comments are more likely to be ignored than when a family speaks English. So kind of based on this background information, I wanted to take a deeper dive into the process of family-centered rounds in the hospital when our team goes into the room and interacts with patients and families and discusses the plan for the day. We did these observations on hospital day 1, and we audio recorded rounds that occurred, and then had families, caregivers who are patients, sorry, not patients, caregivers who are parents, guardians, or family members, whoever was there with the child in the hospital room, a survey right after we recorded rounds. And then we listened to those recordings. We transcribed them. We had a company to transcribe them both forward and back into English and Spanish, and then listened to them and coded for certain behaviors. And so what we looked for in those encounters were certain team behaviors, like how often they asked the family an open-ended question, how often they stated back reflective, like a reflective statement, how often they repeated back what the patient or family had said, how often they asked them what questions or concerns they had, and how often they treated them with empathy. And then we looked at how often the caregivers also participated, how often they asked a question, gave an assertive response by stating their opinion or a preference, or expressed an emotion or worry. And then we kind of had these global count ratings at the end where people who were coding these would kind of say, like, globally, how was the flow back and forth between the patient, family, and the team? How much respect did the team show towards the family? How much partnership was there? How well did the team address their concerns? How much did they give them their full attention? Or were people having side conversations or looking up things in the chart? And how much warmth or rapport was there? And so what we found objectively in this study was that on a positive, for rounds in our setting, all of the patients and families had a professional in-person interpreter present. But even despite having the interpreter there, the communication was different. So patients and families who spoke a language other than English were asked 2 times fewer open-ended questions compared to families who spoke English. The team responded with less reflections. And there was a lot of variability in how much was interpreted, from as little as 10%, which actually was with a bilingual teenager. So they basically had the conversation with the teenager and really interpreted very little for the parents in the room. And then other teams really paused line for line to allow for interpretation to happen. That on average, patients who spoke a language other than English were treated with less respect, less partnership, and there was lower attention and more of those side conversations happening. And we also found that there were a lot of alterations happening in the interpretation from English to Spanish, and I'm going to talk a little bit more about that. So what is an interpreter alteration?
Vicki?
Oh, yeah.
Hey, I'm going to pause for a second. I see that Louisa has a hand raised. I'm not sure if that's related to this, Louisa, or something else.
You know what? By now I should put it down because I just wrote down the question because it was from like 2-3 slides ago. And it was about the wheel with the 4 things that they were looking at. Yes. It was just about whether or not that there was a measure or a way to measure the variable of time between a team member identifying that interpretation may be a resource that they need, and the measuring, I guess, like what is the time lapse up to when that team making the rounds can get it, because if the nurse and the doctors and that interdisciplinary team decides that in their experience it takes too long, and then they have to put that patient at the end or give them worse service because they had to wait, they may be kind of weighing like, what's the lesser of 2 evils that I could give them? And so I think I would want to know the data on what is that time frame, and depending on what the hospital uses, in person, virtual, phone, etc.
Yeah, it's a really good point, and it is an important factor too. I think identifying who needs interpretation, and I know there's some data about kind of how you ask might also influence how people answer or how comfortable they feel. So like if you say, do you need an interpreter, where it sort of feels like maybe you're a burden for asking for interpretation, people might be less likely to say yes, versus if somebody asks, like, what language do you prefer to get your medical care in? It's kind of a less stigmatizing way where people might feel like, okay, I'm going to, say what language I prefer, even if I speak a lot of English, but I prefer a different language. So I think that kind of your question, often for us, will be identified in the emergency department before they get admitted to the hospital that they'll need an interpreter. But sometimes we do have patients and families who, you're having a conversation and you realize that maybe they might benefit from an interpreter, which is a little bit paternalistic, but you feel like maybe the communication isn't going great. And then rethinking like how that was asked or assessed and making sure that you're really delivering care in their preferred language.
But in addition to that, I think the crux of what I'm getting to is how easy or readily available is the service itself, because the hospital is choosing to pay a more affordable service that it requires X number of time, I don't know, put of heads up for them to have somebody ready to interpret, and or whatever the process might be. That impacts, I mean, the point that you're making about where it's identified, whether it's in the ER or once the person is admitted, that's a good point. And I would also be curious to see how the information is translated, not like from language, but from space. So does it transfer well from one setting to the next, that this is a need, right? Are people reading and interpreting what the person meant? What's a standard?
Mm-hmm. Yeah.
But
Okay. Thank you for clarifying. Yeah.
the time frame is really often, and it's often directly correlated to what the institution is willing to or trying to pay for the budget for interpretation for that space. So if I have, all of this would be solved if we would pay an on-site person that whether or not how often they're going to be used, they're there and ready and being called. And if there's too many requests for them, then you pay two of them and successively. But that's the most expensive option that is often avoided. And then you have the system in the way that then creates time, which leads to lack of use.
Yeah. Yes, I completely agree with you. And I think that there is data to support that time is probably the biggest barrier to getting people to both call an in-person interpreter, to schedule one, to be present, as well as, some of this summarizing that happens, I think is an effort to save time, because we kind of have the same time allotted for every patient, whether they speak English or a language other than English. So I think is that more what you're getting at, like time being this huge barrier. And also I think the structures of which some of the systems that we have in place to really support people to use interpreters seamlessly. Because the video interpretation is kind of easier. Now we have computers in the room where you can just call an interpreter immediately and you don't have to go through the hoops of scheduling an in-person interpreter. It's easier, but it is less preferred. And I know at Duke, I've been trying to push people in my group to get an in-person interpreter for rounds regardless.
But I guess my question to that final conclusion is how do we make that, rather than a preference, like a policy? Mm-hmm. Instead of it being like good practice that you or medical colleagues that agree with you take on, how is that implemented at a policy level so that whether or not you have an opinion about whether this is effective, and it becomes less irrelevant and has less of an impact on the patients?
Mm-hmm.
So, Luisa, I'm going to park that very important question for the end, so that we can let Dr. Parente continue with what her findings had been. But I think it's a very important question.
Thank you. Yeah. Yes, we'll get to it at the end. And I will say that there are some groups who are using quality improvement to kind of measure how often interpreters are being used per patient, and then giving feedback, measuring it and giving feedback to their group about, okay, this is how often we're using it. And so that we're not doing that currently, but that might be a way to hold people accountable, not necessarily a policy. Okay, so kind of going back to the content of the recordings that we listened to, we found that these alterations were common. So there were three main types of alterations that happen from English to Spanish or Spanish to English if it was the caregiver speaking. One is an omission, so the speaker says something that doesn't get interpreted, it gets left out. There's a substitution, so the team uses a medically complex word and then the interpreter kind of substitutes that for more lay language, say. Or an addition, so the interpreter adds something that the speaker didn't initially say. And so there's been other studies that have shown that alterations are common in interpretation, and obviously we know that interpretation is not a word for word translation or interpretation from one language to another. It's just not possible to do that. But we're looking at kind of how much is being altered and what's the effect that that might have on patients and families. And there's some studies that suggest that biomedical information is interpreted more than some of the psychosocial aspects. And I have some ideas about why that might be that maybe we'll get to at the end. So in our study, we found that about 2/3 of the time, the content that was being interpreted had at least one alteration, with substitutions being the most common. And often these were actually positive, like the interpreters changing the language to be more patient friendly, followed by omissions. And then lastly, additions, which were often the interpreter kind of checking with the family that they understood something or something was correct. But omissions were very strongly associated with how many words the team said. And it was more common in encounters with kind of children over 10 years old, kind of tweens and teenagers. And that substitutions were often associated with more medical jargon. And that there might have been this prioritization of the biomedical information over rapport building. And I'll say, just having listened to these encounters, a lot of times that's because the medical team would say like, I'm sorry that your child is hungry, and then go on to talk for 2 minutes about, what the plan was for the day. And so that I'm sorry that your child is hungry and we're not letting them eat right now didn't get interpreted because there was so much that came after it. So it's partly due to the way that medical teams use interpreters. And we found that when a team spoke one sentence before pausing for interpretation, that about 1/4 of those had at least something omitted in the interpretation. When they said 2 sentences, it was about 39%. 3 sentences, about 65% had something lost. And if they said 4 or more sentences, there was at least a 90% chance that something would get left out in the interpretation. So how do all these different things that we found affect the caregiver experience and their empowerment to participate on rounds? So caregivers who spoke a language other than English expressed less comfort participating on the survey and greater fear asking questions if something didn't seem right. They also reported that they were less likely to report that their concerns were fully elicited by the team and that they were treated with respect, which matched what our coders felt on the recordings. They felt like there was also less respect. And that on average, a family who spoke Spanish participated 3.3 times per encounter versus a white English-speaking family was 8.3 times. And then only 1 in 10 had complete trust in their child's doctors. And in part, being in the hospital, they're often meeting these doctors for the first time, so that trust really hasn't been established yet. So kind of summarizing some of the differences by language that we both observed and in the literature. First, I think it's pretty obvious that interpreter use is essential for high quality care. And that there's a lot of variability in the communication practices that occur with interpreters. But even when an interpreter is used, there's a lot of inequities in communication that's happening with how the teams talk to patients and families who speak a language other than English. And that families who speak a language other than English are less comfortable, have lower trust, and participate less in these encounters. And that some medical team behaviors are likely associated with some of the interpretation alterations that are happening, like when they talk for a long time without pausing for interpretation. and that those might have consequences not only on the loss of medical information, but also on rapport building and psychosocial support for families. So now shifting gears and thinking not just about language, but also about the ways that race and ethnicity might influence communication quality that's happening during family-centered rounds.
Victoria, there is a question from Sheila Arias. Sheila,
Yes.
¿Quieres hablar en español o inglés?
Yo puedo hablar en español, no hay problema. Yo quiero, antes de que ella cambie de tema ahí, quiero comentar que tenemos ciertas personas que nos comentan que la barrera comienza desde el momento que hacen las citas. Porque, permítame, porque por ejemplo, cuando una persona está usando también un intérprete para hacer la cita por teléfono, a veces no se le explica el proceso o el nombre del doctor que va a ver. Entonces la persona ciertas veces no se prepara en comparación cuando lo hacen con una persona que habla en inglés. Y eso es una de las barreras. O le dicen, mira, tu cita es aquí a esta hora, pero a veces también no terminan de explicarle cómo es el proceso, qué necesita llevar, qué requiere, qué papeleo. Y al llegar a la cita, la persona se ve que no está lista, preparada para esta cita, ¿no? Entonces, también esa es una barrera que es muy frecuente con muchas familias que nosotros trabajamos, donde se ve que no están preparadas, toma más tiempo y al llegar a la cita, la persona que las va a ver, el especialista se frustra porque es pérdida de tiempo y no tiene mucho. Pero yo personal puedo decir que yo he hecho citas en ambos idiomas y en inglés siempre me dan hasta el último detalle desde el estacionamiento. En español siempre es limitado y está esa barrera de que uno tiene que estar preguntando o como que les cuesta o es demasiada información para interpretar, no sé, pero empieza ahí.
Mm-hmm. Yeah, I think that's a really good point, like what your expectation is and what you're anticipating. And I think that's true in this setting too, that rounds itself, sometimes there can be up to 10, 15 people in the room, can be pretty intimidating. And so it helps if patients and families know what to expect in advance and they can prepare themselves for all those people coming in the room and maybe writing down their questions beforehand because it could be intimidating. And so I think that's a really good point, and it is something that one of our bilingual nurses was working on, creating a video in Spanish to help patients and families kind of understand what to expect from rounds. All right, so shifting gears to racial and ethnic inequities. So first, this is built on a ton of literature. So over the last several decades, there's been numerous studies that have looked at inequities in communication with Black and Latino patients. And they have found overall that there's less patient-centered language, less engagement in decision-making, less positive affect, respect, time, and there might be greater conflict and miscommunication that occurs. And there was also a study that looked at this and showed that when clinicians have more implicit bias, that it leads to some of these communication inequities that we see. I'll also note that my research really focuses on Black and Latino populations, given that the demographics of Durham, and then I think my own background as well. But I did want to acknowledge that there's also some newer literature showing that both Asian and Asian American families experience lower communication quality, including high rates of discrimination and disrespect that's equal to, and in some cases greater than those of the patient populations that I study. Okay, so moving on to our observation study of rounds again, and now looking at differences that we found by race and ethnicity, even amongst Latinos who spoke English. So we found that Black and English-speaking Latino caregivers reported greater fear asking questions and less time to ask questions, that they received less respectful and partnership-building communication, that they also participated less, and I have a slide with those numbers, and that they also had pretty low overall trust in their child's doctors. About 2/3 of white English-speaking families had complete trust in their child's doctors, for reference. And so we found that participatory behaviors, which was asking a question, stating your opinion or preference, or expressing an emotion, was on average 8.3 times for white English-speaking caregivers, 5.8 for English-speaking Latino caregivers, 5.1 for Black caregivers, and 3.3 for Spanish-speaking Latinx caregivers, which were all less compared to white caregivers. So kind of the summary was that in general, there's been a lot of documentation of inequities across settings, and that bias likely leads to poor communication quality, and that in our specific study, Black and Latino caregivers were treated with less respect and partnership, and that they had less trust and participated less, kind of consistent with the literature. And so one thing though, going back to the participation, is that really we found the differences in participation were really stark, and they were actually greater than the differences in the medical team communication that occurred. So a lot of times the teams walked into the room and had pretty standard scripted language that they used. They said, "How was your child's night?" And we found that the responses to that question were very different, and the way that the conversation went was very different. Based on race, ethnicity, and language, even more than what the medical teams differed. And so we started to think about what are some of the drivers of communication, not just within the healthcare setting itself, but also outside of the healthcare setting as well. And I wanted to share a story with you that was recently published in a medical journal that I felt like helped to talk about this point a lot. So this is a story written by a pediatrician, a primary care pediatrician, about confronting racism in pediatric care. And so he's talking about there's a child who has multiple comorbidities that he's cared for a long time in his clinic who gets admitted to the hospital. And the hospital team calls him with some concerns. So the nurse calls him and says, "The hospital team is becoming increasingly concerned. They're saying mom doesn't seem to be emotionally impacted by the state of her son's condition. She's not showing up to the hospital until the evening, and she's missing meetings with the care team. They're questioning if she understands how serious his condition is." And the pediatrician says that this was a complete disconnect for him based on the way that he's interacted with this mom in his clinic as loving and caring and very easy to relate to and get along with. And their words were soft and caring in delivery, but clearly they were judging the mom. This mother was not meeting the expectations of how they wanted a mother in this situation to show up and behave. And he says, so he got invited to come up to the hospital. They were going to have a meeting with the mom to kind of figure out what's going on and where the disconnect was. And the meeting went okay, but like I said, the team really didn't, there was still all that judgment there. So after the meeting, he meets with the mother. And he says, "We both lit up when we saw one another, and we had a long talk. She was exhausted. She told me that she was on the verge of being fired from her job because of missing shifts while staying with her child in the hospital. Now she can only come at night after work, after going home to feed and care for her other children, and then taking the hour-long bus ride to the hospital." Then she sighed before sharing with me details of her past that I didn't know. "When I was a kid, my sister was really sick too. When she was hospitalized, my mother was so scared and worried, and she let it be known to the care team. They decided she was acting too emotional, unstable maybe. This led to the hospital watching her closely when she visited, even having security guards sit outside of her room. They started to consider her aggressive for getting upset and frustrated. In the end, they banned her from visiting and called Child Protective Services. We were all put into foster care. It was horrible." She paused. "I'm trying to be as tough and unemotional as possible when I come here. I'm so scared of history repeating itself. I don't want them to get any wrong ideas about me or my children. I never want them to go through what I went through." And so I think that this really highlights how factors outside of medicine can contribute and influence communication that's happening in the hospital. First, this mother's past experiences of discrimination and how that influenced her communication and behavior, and kind of this concept that there can be intergenerational and community level medical trauma that occurs. That mom was really worried about being seen as a stereotype and really didn't feel like she could belong to there, that she could be her authentic self while in the hospital. And that led to her kind of being very closed and shut down in her communication with the team. And also these kind of concept of intersecting systems of oppression with poverty and childcare and opportunity, and how that influenced mom's ability to be present, fully present in the hospital with her child. And so, and really like a lack of the providers recognizing, taking mom's perspective, understanding with an approach of cultural and structural humility, the factors that were at play and contributing to this difficulty with communication with this family. And there have been multiple studies that show when patients experience discrimination in the past, that affects their communication in future medical visits. And so this was just one study where before a clinic visit, they asked patients about past experiences of either racism or classism. And what they found was that Black patients who reported a history of discrimination, often they would describe that as either not being listened to or being treated with less respect, in that healthcare setting would then demonstrate less positive affect towards healthcare providers. And that in turn, their clinicians also then had less positive affect as well. And so clinicians may kind of interpret these cues in negative ways that may reinforce stigma or stereotype about an individual if they don't really understand the drivers of communication and how discrimination might show up in a clinical encounter. And then this was, oh yeah.
Sorry to interrupt you. You know, I'm seeing like the chat is on fire, and I think there are a lot of community stories. Would it be okay if we paused here and see if folks have things they want to react to or share? Would that be okay?
Yeah, I think that's great.
Okay, thank you. There's so much. I feel like this could be like 3 different 19 talks, but I know a lot of folks have questions. I wonder if anybody would like to share perhaps anything that they have heard, a personal story or anything where this connects, like this resonates, and how you or your family or, you know, anonymous may have experienced some of what Dr. Parente is talking about today.
I see Jackie Hernandez raise her hand, and then Sheila.
Hi, yes, can you hear me?
Yes.
Okay, I have my little one with me, so I apologize if she's screaming or something. I would like to say first that I am very happy with the care that my kids are getting, you know, here, especially at Duke. And my older daughter, who's just turned 4, she is now just being referred to an autistic evaluation. They think that she might be in the spectrum because she has speech delay. So we're like kind of like in the process of getting everything together, and also ourselves as a family processing what's gonna be new for her, or what are the changes, you know, in the care that we need to provide for her. Also, at the same time, I feel a little bit frustrated because when we go to the doctor, we don't feel as comfortable as when I take my younger daughter for her appointments, because my daughter, you know, she doesn't like when people get near to her, so we can't get weight accurately or height accurately or other things that are usually very easy for my youngest daughter. We recently went to the 4-year checkup, and they told me, oh, you know, we don't have a measurement for her height that's accurate. We're worried about that because, you know, the chart is not going up as it should be on paper, you know. And I told them my daughter is actually very tall. So I told them, you know, I think she's growing up. She's she's doing fine, you know, in that aspect. And they send me to the specialist because they say that on the last measurement they got on the chart, she shrunk, which I think it was kind of like impossible, right? So for me, it gets a little bit frustrated there because now I have to take her to the specialist, and it's gonna be another adventure, you know. She's not gonna let them get near her. They're not, if they try to get blood for hair or any other treatment or an ultrasound or any labs that they need to do for her, it's going to be a very traumatic experience for her. So I think that I wasn't I don't think that my doctor is bad. I like her a lot. I'm just saying that I feel like she didn't listen to my concerns, and there wasn't a really good communication with her. We were speaking in English and all that stuff, but I think that, and I understand her concern, and I think that you know, they need to make sure that things are going fine. But also, you know, that little piece where I left the doctor and I felt like you know, she didn't listen to me. It's a little bit frustrating for me. I also wanted to comment about the interpreters that we were talking about. In my experience, I don't mind when they send them into my room because, you know, I know that they see Hernandez on my last name, and sometimes they assume that I need the interpreter, and it's fine. I will speak Spanish. I will talk to them. I will try to get that conversation going. The problem for me with that is that if I'm gonna be at the doctor for an hour on a regular appointment, when I need the interpreter or when they trying to get an interpreter for me or my family, then it's 2 hours, or, you know, the wait is longer. Yes, mama. And then sometimes when the interpreter is in the room, yes, the interpreter is in the room, we have this problem because they see me nodding at the doctor's comments before I get to talk to them and say, sí, esto es lo que está pasando. Entonces, they notice that I understand what the doctor is saying, and then it's like, and then another barrier starts because they feel like, I don't know if they don't feel appreciated or they don't feel needed then. And then I had two that left the room, or they told me, ay señora, usted no necesita el intérprete, entonces si va a responder antes de mí, or, you know, things like that. And yes, mommy. And that's, I'm sorry. And that's some of the issues that I had. And also when we get the interpreters and they are saying other words that I know that are not the words that the doctor is saying, then that is something kind of like a red flag for me. And that's why I personally don't like to use their services when they ask me if I prefer to have an interpreter or not. And I'm sorry it took such a long time.
Thank you for sharing that. I think there were a lot of really powerful stories there. Viviana, do you want me to just keep?
Yeah, I was Sheila y luego Sirana.
Sí, yo quiero comentar algo que dijo la señora. Yo, en lo personal, nosotros trabajamos con madres que tienen niños con necesidades especiales más y condiciones médicas. Y sabemos que en sí esto ya es un caso muy difícil para muchos padres aceptar o aprender de ciertos diagnósticos que no han conocido de dónde vienen en este país, ¿no? Entonces, una de las cosas que es muy difícil cuando están trabajando con ciertos doctores que no tienen que no tienen tanto conocimiento en cierta cultura, es que muchos padres, por ejemplo, no contestan con sí o no con las preguntas, ¿verdad? Sino que lo miran porque es cultural y eso quiere decir que entiende. Y también está cultural de que en nuestro país no cuestionamos a los doctores por su título y pensamos que saben y todo, ¿no? Entonces, eso lo hace muy difícil. ¿Por qué? Porque yo tengo padres que han aceptado diagnósticos que no deben de aceptar, o sea, que no quieren, pero se sienten como, no se sienten con la confianza y no se sienten libremente de poder decir, no quiero aceptar esto, necesito una segunda opinión o pienso que es muy temprano para este diagnóstico, déjeme esperar. Por lo mismo, pero por el temor de que piensan que le van a quitar al niño. Y creo que ese es un temor que tiene mucho aquí en nuestra comunidad, es de que todos los servicios, porque no han tomado el tiempo y porque hay mucha mala información, los relacionamos muchos padres con social service, ¿no? Donde vienen, te ven en los que están en la casa y casualmente es donde determinan si te van a quitar el niño o no. Ese no es en muchos de los casos, pero también los doctores, por ejemplo, más con los niños que tienen necesidades, cuando hacen las referencias para terapia ocupacional o cosas que tiene que ver a venir a la casa. Tengo muchos padres que dicen, pero es que me dicen que alguien va a venir a mi casa, pero nunca me explican quién, porque no toman el tiempo de explicarme quién, no tiempo el tiempo de decirme a qué exactamente va a venir y que en verdad tiene que entrar a mi casa y por qué. Entonces, casualmente solo dicen, te vamos a mandar una persona. Y cuando la persona llega a la casa, pues muchas veces es por eso que los padres no abren la puerta. Nosotros estamos trabajando mucho en eso porque hay un porcentaje muy, muy bajo de padres que siguen el seguimiento del cuidado para los niños de 0 a 3, que son las terapias del habla y todo eso. Por lo mismo de que cuando van a la casa no hablen, porque no hay esa comunicación. O a veces les manda la información en papeles, se las dan y no saben ni si el padre puede leer español o no. No toman el tiempo de preguntar, señora, ¿usted habla español o qué nivel entiende? A veces le dicen, yo estuve en un caso donde le dijo el doctor, dígale a su hijo que se lo lea si usted no sabe. Y yo digo, pero, ¿y qué suponer que el niño va a leer y que sea un niño de 10 o 12 años? Es un adolescente en términos, ¿verdad? ¿Qué conocimiento va a tener él? Y no se lo podemos dejar la responsabilidad a ellos, ¿no? Entonces son esas de las cosas que tenemos. Y yo en lo personal, cuando mi hija me dijeron que tenía un diagnóstico, yo hablo inglés y eso fue hace 14 años. Yo lo primero, de la manera que me explicaron en el regional, en el hospital regional después de que nació, la manera de que me lo explicaron fue con tanto temor que cuando me hablaban o me mandaban información, yo no contestaba las llamadas. Yo no tampoco abría la puerta. Eso me llevó a negar muchos programas que tenía que hacer para mi hija y tuve una trabajadora social, pero la iniciativa fue por eso, porque nunca me explicaron y era como que me sentía que iban a invadir mi espacio y que no era, o sea, no me lo explicaron de una manera que yo lo podía procesar y entender que era una ayuda específicamente para ella y no para que vinieran a ver si estaba haciendo mi papel bien como madre o no.
Gracias, Sheila. Voy a pasar a Sirana. Tenemos poco tiempo, entonces quiero que tratemos de ser breves. Sirana, Edgar y Kena, adelante.
Okay. Thank you very much. This is a lot of good work, and I appreciate talking about the race and ethnicity piece as well as language. I feel like because I've been attending these, we had an amazing session after Latinidad, and I just feel awkward now looking at categories that say Black and then Latino. So I just wanted to say that I have feelings about it. I'm not sure how one goes about fixing that. And then I also, because we had someone talk about the LGBTQ plus population, the Latinx, it can be not something that people identify either. And so there's no right answers, but I just, as I appreciate your effort to talk about race and ethnicity, there is like a whole level of how to choose terms that feel more inclusive and comprehensive. Thanks.
Thank you, Sirana. Kena and Edgar, I know you are together or you have. ¿Quién quiere comenzar?
Hola, buen día. yo creo que mi esposo diría las damas primero. Por eso dije. Gracias por dejarnos ser parte de esta importante información. Una de las cosas que yo he tenido, tengo una niña de 7 años recién cumplidos, que ha tenido retos de salud desde los 2 años y nos hemos enfrentado a un sistema que en emergencias puede lograr hacer muy bueno, pero en la consulta del día a día es un sistema muy lento. Tan lento que mi hija tuvo que ser operada de emergencia y tuvo que perder su vesícula. Pero en cuanto a los intérpretes, yo entiendo muy bien el idioma, si se me habla. Lo complejo para mí es hablarlo. En nuestro caso, tengo la ventaja que mi esposo, cuando pasaban emergencias o cuando había que estar con un doctor presente, él dejaba de hacer lo que estaba haciendo para asistir y ser de ayuda, porque nos pasó donde yo solicité intérprete en algún momento y creo yo que tiene mucho que ver que a veces no se entienda por la diferencia de nacionalidad, por la diferencia en cómo hablamos el español en toda Latinoamérica. Entonces, esa fue la barrera que yo encontré. ¿Qué fue lo que yo decidí? No tener intérpretes y me pasa lo mismo que allá aquí. Cuando tienes un apellido latino, se te asigna, pero yo siempre digo no. Han sido pacientes cuando yo hablo, pero mi esposo siempre trata de estar presente para ser él el que esté diciendo las cosas más fluida y como al final él y yo conocemos a nuestra hija y su padecimiento, es mucho más llevadera la interpretación que él puede tener conmigo cuando yo no alcanzo a traducir una palabra de español a inglés. Entonces, una de las cosas que yo le decía a mi esposo, deberían de tener a alguien permanente en el front desk que ya casi que tenga la insignia de hablo español para recibir a todos estos latinos, que pasa lo mismo, cuando tú llegas al front desk, te puedes llegar a sentir nervioso de no saber si te vas a dar a entender y vas a recibir y entender la misma información. Ese es mi comentario. Gracias.
Gracias, Kiana. Había unos comentarios en el chat que creo que también eran importantes. Y entre ellos estaba la pregunta de Luisa. It was the question from Luisa. What are the policy implications? What do we do to make sure that the language assistance is offered? I don't know if Luisa, si tienes otro comentario, if you have a different, or Victoria, if you want to answer to some of the comments that were shared before.
Yo sé que ya estamos a la 1, so Victoria, muchísimas gracias. Creo que empezaste una conversación muy, pues obvio, súper caliente para todos nosotros acá, pero también importante que nos toca el corazón. Parte de la razón que yo estuve tan ready to jump es que me pasé el lunes por la noche en emergencias con mi esposo y hoy por la mañana que él ha estado hospitalizado por algo personal y vi en práctica muchas de las cosas que vamos presentando y mi cerebro siempre está como brincando de lo personal y lo íntimo a la data y los números y cómo cómo eso refleja y cómo impacta. Y mucho de lo que estábamos platicando, las observaciones que se hicieron y conclusiones del el estudio se reflejaron en la experiencia que he tenido en las últimas, 24 horas o 2 días, no sé cuánto llevo ayudando con eso. Y, en fin, yo creo que, pues, para mí tengo tantas ideas o pensamientos que quisiera, si hay una oportunidad, vi ahí que está el correo, me encantaría platicar como offline, especialmente viendo los paralelos que existe para uno crear ese espacio donde la persona se sienta seguro dentro del sistema médico que hay para los padres sentir esa misma seguridad y acogimiento en el sistema educacional, que es lo que nosotros estamos trabajando aquí en Isla. Y me encantaría como pues poder como mirar más a fondo esas conclusiones, cuáles fueron las observaciones, el estudio, y ver qué información o qué results o recursos se puedan extraer para nosotros poderlo utilizar en este mundo, pues que tienen ese mismo paralelo de servicio a la comunidad que habla español. Pero sí, mil gracias, súper agradecida, ¿no?
Gracias, Luisa. Le voy a dar la palabra a Edgar, que la había bajado y perdí de que hablara. Edgar.
Muy buenas tardes. Feliz Día Internacional de la Mujer. Feliz Mes de la Mujer. Miren, me quito la gorra en agradecimiento a su liderazgo. Tantos rostros que se ven aquí de mujeres de tanto valor y tan valientes y que son líderes, son punta de lanza en sus respectivos campos en cuanto a la lucha por la justicia y la equidad. Así que felicidades y gracias. Como hijo, como nieto, como esposo, como padre, celebro este día y hago un énfasis en la importancia de la equidad de género para nuestras mujeres en diferentes ámbitos, reconociendo que este día se celebra por una lucha por la justicia, que así inició el enmarcar de este día, ¿no? Me pidieron que fuera breve, ya reprobé el examen, doctor. Bueno, rápidamente, una experiencia, como mencionaba mi esposa, que me siento tan bendecido de que ella participe en la conversación. eh, una experiencia que tuvimos con nuestra hija recientemente, en una consulta con un pediatra. Estaba ya teniendo una situación que requería varios estudios, porque había como una situación viral ahí, pues extraña, ¿no? Y uno de los estudios era un examen de sangre para ver si había una infección en la sangre. Y no sé si el doctor en este caso era nuevo o no estaba muy familiarizado con el lugar donde estaba ofreciendo la consulta, pero él nos envió a realizar ese estudio específico de sangre en el mismo edificio donde fue la consulta. Y esperamos pues unos minutos ahí. Y cuando llegamos a realizar el estudio nos dijeron que en ese edificio no se realizaba ese tipo de estudio. Entonces nos devolvieron al área de recepción. Todo esto es en inglés, obviamente. Y en el área de recepción nos dijeron que estaban buscando dónde hacían este tipo de estudio y nos querían mandar a Wake Forest, como a 1 hora de distancia. Y dije, pues no hay algo más cerca. Perdón. Y bueno, para esto pasó pues más de media hora, 40 minutos ahí esperando. Entonces nos enviaron finalmente al hospital de la Universidad de Duke, en el área de clínicas. Y bueno, fue difícil, íbamos con prisa. Yo llevaba a mi niña caminando, ella se sentía muy mal. Hubo estacionamiento hasta el 4º nivel, ¿no? Hubo que caminar bastante. Y llegamos después de más de 1 hora justo a la clínica, la letra de la clínica que dijeron y demás. Fuimos a registrarnos y me dijeron, bueno, señor, lo que pasa es que aquí no atendemos personas menores de 15 años. Y mi niña tenía 6 años, ¿no? Entonces, nos enviaron al hospital infantil, que está en el mismo complejo, ¿verdad? Sin embargo, ella se sentía mal, teníamos que caminar hasta allá, entonces yo conseguí una silla de ruedas para llevarla. Este, total que fue un proceso bastante frustrante ese día. Gracias a Dios finalmente se logró el examen de sangre, etcétera. Am, pero durante todo ese tiempo yo estaba reflexionando, si este fuera un padre o una madre o una abuela, un abuelo que no hablara inglés, yo no encontré señalamientos claros en un idioma que no fuera inglés. No había personas en las áreas de recepción que hablaran español. Entonces empecé a reflexionar en lo compleja que sería la situación para una persona que no hablara inglés o que no dominara el idioma. Y eso pensar también en familias inmigrantes que vienen de otros países que no son de habla hispana, porque aquí, pues, relativamente es más sencillo encontrar apoyo para personas que hablan español, pero si pensamos en personas que vienen de otros países, de África, por ejemplo, del Medio Oriente, etcétera, que hay eh, una comunidad y que emigra de esas regiones del mundo considerable en esta parte de Carolina del Norte, pues la reflexión era esa, ¿no? ¿Cuál sería los retos o el dolor, ¿no? Que viviría esa familia? Y ya, lo voy a dejar ahí, doctora.
Gracias, Edgar. Nos quedamos sin tiempo. Gabriela Maradiaga, sé que tenías un comentario. Lo siento, Wendy y Sheila, que están con la mano levantada.
Quería dar las gracias a la doctora Parente por venir y a todos los miembros de la comunidad por compartir sus historias. Esto es algo obviamente muy complejo y es importante que alcemos la voz los que podamos, cuando podamos, porque muchas veces la pregunta de Luisa es muy acertada. ¿Cómo cambian los sistemas? Para que el sistema cambie, tienen que haber incentivos o penalties. Y muchas veces cambian cuando los pacientes se quejan y nuestra comunidad no es quejona. Entonces, a veces las historias personales impactan porque alguien en una oficina no se da cuenta. Por ejemplo, la experiencia de Pastor Edgar y la señora Kena. Y también el dinero, no hay incentivos monetarios para prolongar visitas con intérpretes y esas cosas afectan los incentivos de los hospitales. Entonces, en todas las maneras, los que podamos alzar la voz, es importante alzarla para que la gente se dé cuenta de estas cosas y los cambios sistémicos se hagan. Y agradecemos a los líderes que están poniendo atención y están tratando de hacer cambios y seguimos siendo tábanos, como dice Viviana, para motivar los cambios. Gracias nuevamente a todos por estar aquí hoy y compartir sus historias.
Y Victoria, si, if you are able and willing, we would love to follow up this conversation in April. I think it is such an important, es una conversación tan importante para seguir. Muchas gracias.
Yeah, thank you again. And I put my email in the chat. Please reach out to me if anyone wants to talk more offline. And we are planning some next steps of an intervention. So if anyone wants to hear more about that or give feedback, that'd be awesome.